discussion. But
you ready?
Yeah, sure.
Okay, why don't we go ahead and get started. Welcome to all you stalwarts who are back for a second presentation today. Our speaker is someone that probably most of you know, Dr. Holly Jimison, who and when I introduced our previous speaker, I said even though I had introduced him a number of times, I had to read off the thing. Actually, Holly I know so well, I don't even need to read off the thing, because actually Holly's one of the first people I met when I started this informatics journey. I was a resident and went out to look at the programs at Stanford and UCSF, and Holly was a PhD student in informatics at Stanford under Ted Shortliff when he was at Stanford, and we also kind of hit it off because we're both from Chicago and both went to University of Illinois. So anyways, it just, for those of you who are fellows, it shows you that the people you meet in your fellowship may be people that you know for quite some time. I was actually chatting with someone in the dean's office today who another person I met on that trip was Mark Frissy, who also I still know as a longtime friend and colleague, and she actually knows him because she was at Washington University because that's where he went after he finished at Stanford. So it is amazing the lifelong friendships and relationships you make. Anyways, but I guess that kind of plays into big data because it gives us a lot of data. So we're going to hear today about big data, which if you haven't been paying attention, has become a buzzword. But it's more than a buzzword, and it really reflects a major direction that really not only biomedical informatics, but a lot of fields are going. And there's also a lot of societal implications for all the data we're accumulating and what we do with it. So Holly is going to, one other thing, Holly's been, even though she's still on the faculty and actually teaching, mostly through distance, but still mentoring a few of you, she's actually been spending most of her time at NIH, and so she's going to inform us of some of the work that she's done there and let us know what's happening in this area. So.
Yeah, thanks, Bill. I do remember that visit well, even though it was many years ago. And yeah, you're right, the fast friendships that come from these social networking. I have been at NIH half-time for a year now. My main responsibility is working with the Office of Social and Behavior Research on big data issues. And what's been interesting is that the work we're doing here at OHSU is very, very relevant and at the forefront of the type of data that they're interested in. And that has to do with why I put the bottom part, monitoring behaviors. You know, Dan Macy's, who you heard from this morning, or around the noon hour, he came to NIH years ago when big data was just starting. He told Francis Collins, the head of NIH, and others about what was happening in genomics, proteomics, even imaging. He never mentioned at that time behaviors, and this is a whole new area ripe for discovery. So my group, the Office of Behavioral Social Science and NIH, they're really interested in making sure that we capture the attention of NIH in addressing the increasing complexities of monitoring behaviors in the home and environment. I'm going to try to show you how this is going to be a really hot next topic. Clearly, as Bill said, this is a new buzzword. It's big. We all know it. And it was March of last year that the federal government just poured a lot of money into this, and every single organization in the federal government that deals with data got on board. And even companies as well. At NIH, we had 28 different initiatives in this area. But people are developing their skill sets and even developing their own intuitions about what big data means based on personal experience, and it's always limited. People working with large genetics data sets, the issues are, well, the volume. How do we reduce the volume? Molecular biology, they develop their own issues. Companies, most of computer science people are being drawn towards Yahoo and Google, helping them do better advertising. I would like to take that talent and move it toward health, and especially in some of the new areas that we're seeing, because health behaviors in the home and environment really have specific new challenges, and I'll try to describe some of those. Part of it is just how do you sample? How do you represent context? Typically, we're trying to get by with noisy, free, ubiquitous data that's available that describes how people are interacting with devices or simply activities in the home and environment. And this requires new analytic techniques. Healthcare reform is moving us in the direction of being more concerned about behaviors in the home. We're moving away from what you see on the left, episodic reactive care, towards proactive preventive, hospital-centric to patient-centric, and what's happening in the home. We know that most of healthcare actually takes place in the home, not in the clinician's office, not in the few times you're in the hospital, but you're making healthcare decisions, especially about chronic conditions, in the home when you're managing your own health and well-being. We're moving from training and experience-based, apprenticeship-style training, and more evidence on protocols, and technology-based decision support becomes more important. Interoperable data is always important, but also integrating patients into the healthcare management is patients, family members, and informal caregivers as well, which you'll see as we go along. We know that we're spending way too much money in the U.S. on healthcare for poorer outcomes than we see with others. And this is due to a changing demographic and aging demographic in many countries. It's already a crisis. The healthcare expenditures are, they've eked up gradually, but certainly everyone's considering this a crisis. The OECD countries, the Economic Development Group, they are now moving towards looking at healthcare specifically because it is sapping up so many of our, it's going to be an economic disaster, and probably more effective than terrorism as something that we should be really looking at. So in this new world order, what are the issues that are causing the expenditures? It's the chronic conditions, things like obesity, and clearly when you start looking at how are the dollars spent, the way to address this is by health management in the home. And but as you start to collect this, the issues of big data loom large. Analyzing this type of data becomes extremely challenging, and we need input from modelers, from computer science and engineering, as well as from people that are familiar with the healthcare domains. So the opportunities here are immense. We need scalable, low-cost approaches for these kinds of home health solutions. It's looking at health behavior change becomes really important. That's not something that's well addressed by our standard current medical care system. And to do good health behavior change requires tailoring, understanding the patient, what the activities are at home, and adapting your interventions to individuals. But as you do this, and as you're getting monitoring data from the home, there are a variety of sources. This in itself makes it unique and very different than many of the people that are just looking at web clicks, just looking at microarray data or something in molecular biology. We have noisy, low-cost data from a variety of sources, different reliability, different biases, different contexts that have to be represented, and the smarts go into the algorithms in optimal inference, where you're carefully fusing information from a variety of sources to understand an individual's activities. But again, people haven't looked at this data. And maybe just as one concrete example to talk about, we're now monitoring sleep quality in the home. The data has not been looked at, how sleep is affecting other areas like depression, like cognitive impairment. We know that from specific studies where they carefully monitor sleep that this is an important factor, but it hasn't been considered previously as a measurable activity of daily living. Now, this type of data gives us many new challenges because of the diversity of it, the complexity. It's longitudinal, goes on and on and on, not just for a short period if you're doing long-term care. And it's distributed a variety of sensors with characterizing them in different ways. One of the issues is to keep the new approaches low cost. The sensors are going to be inexpensive and inherently noisy. And one of the contributions in medical informatics is more than focusing on the device, you're focusing on the algorithms to interpret noisy, complex data from a variety of sources. And I'm hoping that our field can really be the ones at the forefront of making these new discoveries and new recommendations for approaches to care here. But it really means we need new statistical approaches and modeling techniques to address this. And I'll mention up front, one of my goals at NIH for this coming year, I'm doing a rotation there for 2 years, and the goal I have is to develop a training program that helps multidisciplinary teams work together to solve these kinds of problems, to have shared data sets and address the barriers that we currently see in having new people get into the field and help solve problems with still having clinical expertise to guide the questioning. So, still need new advances in machine learning, data mining, but also just helping people work together on these issues. Now, companies have always been interested. The financial markets, they're the first out there with a lot of the algorithms taking in economic information. But there's global positioning system data that's out there. People can look at purchasing behaviors, computer interactions on social networks. Facebook itself has more than 4 billion photos. And what are the opportunities there? But the data is all similar. An example of searching behaviors from Google was able to outdo the Centers for Disease Control in looking for flu outbreaks. I'm sure a lot of you have seen this already. You can do this with looking at purchasing behaviors of over-the-counter drugs. Whenever a flu outbreak comes up, people are suddenly buying all the flu or cold medications. And a lot of this data is free and out there. And you'll see what... I guess I should interpret this. The yellow line is CDC's data on reports of flu. The blue line are the Google estimates simply by looking at searches related to flus and cold symptoms. And you'll notice Google can anticipate in many cases, or at least do as well. This is a typical kind of outbreak periodic in time. And certainly, Google can easily see, detect other types of outbreaks or types of symptoms that would crop up, and even can do it locally. And currently, now can we do the same thing with data in the home, where we're getting data from a lot of different sources, different types of sensors? What we currently have in the home of many patients with chronic conditions, the typical ones where their disease management systems are diabetes, asthma, and heart failure. But there's also wellness systems out there with diet, exercise, smoking, where you're trying to change health behaviors. And some systems for looking at fall detection, activities for older adults for safety reasons. But in addition, there's many sensors, wearable sensors for monitoring EEG or EKG on the fly, blood pressure on the fly, accelerometers. You probably all have some of these devices yourself for helping you, even the pedometers you're wearing, to increase your number of steps per day. This kind of data can be useful for home monitoring. But in addition, we want to think about what are the new behavioral markers. And when, you heard Dan Macy's this morning talking about biomarkers and the big issue of biomarkers and genetic data. Now, if you add the intelligence derived from potential new behavioral markers that are clinically relevant both for diagnosis but also for monitoring interventions, some of them I'm going to describe are from Orcatech here as examples of behaviors that can be modeled in the home. So we'll look at activity monitoring, cognitive monitoring. Looking at motor speed is a great indicator of early indicator of cognitive decline, and also other conditions, perhaps depression, just hasn't been looked at yet. Suddenly we have the ability to unobtrusively, continuously monitor walking speeds in the home. Simple indicator: sleep, socialization, physical exercise, medication management, depression, a variety of topics. I'd like to just give you some examples. And the funding, I always should mention, comes from initially NIST and Intel, Alzheimer's Association, National Institutes on Aging, and NSF. So many of you have already seen this diagram. I just want to remind you of some of the sensors that we have in the home from Orcatech. In the upper left are this very simple Radio Shack style passive infrared detectors of motion that are in many of the rooms here. We restrict the field of view so we can put some in the hallways, and that's what we use. Very simple, cheap measure of walking speed. And you're getting it continuously, several times a day. All the computers have our cognitive computer games on them, as well as monitoring typing speed, linguistic complexity, door switches so we know when people go in and out as another indicator of socialization. We have Skype and webcams on all the computers. We get people to encourage them with coaching to interact with others. Bluetooth-enabled medication dispensers in many of the homes, and now starting with cameras underneath to detect that. But once you have those images, all these sensors, you're getting data streams coming in to the server, a variety of indicators. You'll notice, just for example, typing speed for motor, which corresponds with the neuropsych test of the finger tap. Walking speed, another motor test. You can combine these over time and disambiguate true motor speed from complications that might be due to arthritis or a particular foot problem compared to the finger problem. And we can get from our computer games additional measures of motor speed and then measures of memory, divided attention, as you've heard from Zephy before. Now, given that, you can take the sensor firings, these simple motion sensor firings, and infer a layout of a home by looking at the paths taken and finding legitimate paths and infer which is the bedroom, which is the bathroom, kitchen. We also have sensors on the refrigerator. We infer eating behaviors. So that's one way to handle the big data and simplify the representation. Another thing I want to bring up as a big data technique is data visualization and how to handle large amounts of data to develop hypotheses that you can later test and fuse information. We were using this particular representation to look at sleep behavior. But meanwhile, we needed to understand what is normal for a person's sleep. You know, huge amount of sensor firings are coming in. In this case, it's a polar plot representing midnight at the top, around to noon at the bottom, and back again. Day 1 in the center circle, and over a year to the outside. So you'll see this upper quadrant, they're in green dots, mean they're in the bedroom. That's the sleep time. This person has good quality of sleep, little restlessness and time out of bed in the beginning of the year, and then develops poorer quality of sleep. But from this kind of plot, we can devise our algorithms for defining what we think is normal for this person. What's normal onset of sleep, normal bedtime, and normal wake time. They clearly are in the kitchen, so we know there's normal eating behaviors, breakfast, lunch, and dinner. And we can tell how often they go out for socialization. This is a data visualization technique for big data that helps us take this one type of data and develop hypotheses and methods for developing features that might be useful for, in our case, we were first looking at defining sleep quality. Now for another person, same type of plot, but this person lives in a residential facility where they go out to the dining room for breakfast, lunch, and dinner, clearly in the bathroom. They have very normal pattern, but the sleep quality's poor. We can tell from this normal time for going to bed and waking up, but we can develop an algorithm that will measure sleep quality that's normal for this person. And also, we can tell what's normal for safety reasons and what we communicate to a family member. If this person did not go to breakfast or was, did not get out of bed until at all, you might do a soft alarm to a family member. You can use these types of data visualizations to figure out what the algorithm should look like for soft alerts. But this is just one type of data, huge amount of data. Another type of data visualization that's useful for these data streams is to take our example of walking speed in the home. Remember, we had sensors at the top. In the diagram I had only had 3. Sometimes we have 4, depending on the length of the hallway. But in looking at walking speed data, we used a data visualization technique like this. This is time across the bottom, going from December 2007 to 2010, and then velocity, the walking speed on the ordinate. And so the peak of these distributions are the warmer colors. You'll see this person was walking at about 75 centimeters per second for a while, a little bit less here, had a stroke, and then you can see he recovered, but never got back to normal walking speed. If we only had better data that we could mesh it up with, we might look right here and see, was that another type of stroke, or maybe a transient ischemic attack, or something what happened here? We're taking weekly health reports that we can link up, but need to go back and look at these types of data because that was a very similar type of event, descriptively. Now, if we can capture that in real time and know when to intervene or send an alert, these types of plots help us in developing algorithms, but we need to look at many patients to do this right. Walking speed is a hallmark of cognitive decline and is used as a standard neuropsych test, along with the finger tap. Both of them look at motor speed. Of course, neuropsychological tests are also have tests, paper and pencil tests for memory and planning abilities, word recognition. Now, here, we would love to know a single subject's walking speed over time and be able to look at the trend. this person received a diagnosis of mild cognitive impairment, right where that arrow is. But you'll see the trend was going down for, 2 years earlier could have been detected. One of the problems with standard neuropsychological testing is that people are tested and then compared to a population. And they're tested only once a year, typically, and it's very expensive. If you could be taking very simple data like this as one feature that you could then use with others to judge whether somebody was having a slowing in general of their motor speed that would indicate cognitive problems, you could detect and test these potential drugs for dementia and Alzheimer's at a much earlier point in time when they might actually be more effective. Or build cognitive reserve through techniques like we try to do with cognitive health coaching. Socialization is another type of data that we don't tend to look at in the home. And yet we know socialization improves cognitive performance. It improves depression outcomes. It improves quality of life and even standard health outcomes in general. But it is not part of standard medical care currently. Now, if it could be offered as we're trying to do with our socialization interventions in a low-cost, scalable way, we would want to be able to take socialization data as another behavioral measure. Our current technique is looking at phone usage, not only time on the phone, but number of contacts. Same for email. Amount of email and number of contacts, not including spam. If there's an easy way to filter that out, I know. Skype, we use, since all of our people are on Skype, we monitor time on video and time on chat and derive a composite measure, as well as we need to integrate the number of times out of the home and presume that as a social encounter. You'll know a lot of this that I'm describing, it's very indirect. We're making big inferences, and it's noisy, context dependent, might be making mistakes, but we do have a lot of data. It's the beauty of big data is that it's personal. You can look at within subject trends, and lots of data gives you the ability to infer an accurate estimate. Another one that's looming large on the frontier is sleep disorders. Really underreported, undertreated. Typically, people are brought into a sleep lab, and one of our PhD students in biomedical engineering has a son with sleep disorders, and this is a picture of his son, thrown all kinds of electrodes and sleeping in an unfamiliar environment with you can see this is so unnatural and probably not representative of the standard sleep. Very expensive. Typical visit to the sleep lab is about $2,000. This student worked on a sleep apnea detector as a screening tool in the home. Just as an example of how he modeled this, put load sensors under the bed that we've tried a couple of different types of load sensors, but currently we're measuring sleep quality just with our motion sensors, but some of the homes do have these types of load sensors under each bedpost. And with that data, you can measure forces on each one and actually get breathing rates, breathing signals, respiratory rate, just by looking at the center of mass up and down, presuming that the person's lying vertically in the bed is normal. So as they breathe in and out, the center of mass changes. And this is a very slight signal, but you can measure it, especially over time, get signals like this that correspond to the standard sleep lab signals. In the sleep lab, the top two blue lines look at thermal peak flow for respiration rate. The black here that says load cell is Zach Beatty's, the PhD student, his interpretation of the load cell center of mass changes to derive respiration rate, and it corresponds beautifully. And the black bars are the apneic episodes. Then they'll have, you saw the sensors around the chest and the abdomen and leg sensors. And with the load cell, he can also look and detect changes in leg movements. So, and this is done in the home completely unobtrusively if you're collecting the load sensor data from under the bed. Now, jumping again, what's another simple measurement you can make in the home that might have value? And that's simply computer usage, time on the computer. We have a group of subjects that are average age 85, range from 70 to people over 90. But we look at their computer time. In this case, it's a period of months, from 0 to 32 months. And look at, for each individual, mean days on the computer, and looking at those that are intact. These are actually population estimates now. Just seeing, can we separate cognitively intact people from those with mild cognitive impairment? And people with mild cognitive impairment are declining in their computer usage. Now, this isn't a definitive diagnosis when you slow down or use your computer less. But what I'm trying to portray is these are easy to measure, clearly noisy and context dependent, but if you take data from an individual, you look at trends, and then you also consider the other types of behavioral data that you have that might give support to this type of diagnosis that you're after. This is brand new types of behavioral data that have not been analyzed for a wide variety of potential clinically important diagnoses, early detection, and these might be indicators that would be useful in interventions as well. Now, you've all probably heard too much about our love of computer games, but I have to bring it up. Zeffy does the two-dimensional blackjack game, and he has some beautiful new results that you'll be hearing about soon. Crystal has been working on the memory game and has a beautiful model of memory decay and an estimate of memory buffer length. Stuart Hagler has taken this last game. Maybe I'll go into a little more in depth on that, just because this is a game that is very similar to a standard neuropsychological test called trail making. Trails A makes you connect 1, 2, 3, 4, it circles on a page. And Trails B adds the additional level of cognitive complexity of asking you to go from 1 to A, 2 to B, 3 to C. So you're alternating between numbers and letters. Takes you longer. It's that difference between simple search and the cognitive additional complexity of set switching that they use to measure executive function for a wide variety of neurological conditions. Now, in our game, and Zeffy's worked on all of the games for years when it was first funded by the National Institute of Standards and Technology, you give a search string up at the top and then have ask the person to click, click, click in order the correct letters. And then you measure that time. The scoring for these games is very different from, the scores are meant to motivate the person, get them to keep playing and have fun. What we're doing in each of these games is extracting measures of cognitive processing that are required to complete the task. In the memory game, we're looking for memory indicators. In Zeffy's blackjack game, it's a divided attention indicator. Here we're looking to correspond with the standard trail making test by modeling individual components. And I'm going to talk later about, for big data, what's required. Do you just simply do machine learning to see what happens? Or do you use structural modeling to try to figure out, separate out recall, from search to move, and then separately from that, the cognitive process. So what Stuart Hagler was able to find in our data, using this kind of modeling technique, he compared our model from the game, the extracted measures, understanding what component was motor speed, what component was search, and what component was cognitive, to the actual neuropsychological test score. And remember, I talked about Trails A just being 1, 2, 3, 4, 5, the search for the numbers on the page. They're down here. Each individual person is a circle taking Trails A. Then their scores on Trails B, of course, are longer, but you'll notice it's a nice tight fit comparing what we can extract from a game to a computer version of the standard trail making test. And this kind of correlation is comparable to test reliability, doing the test one right after the other. This is phenomenal, completely new. But you can imagine it's another data stream coming in that has to be analyzed and somehow mashed up with other indicators of cognition. You'll hear about this more from Crystal at some point, but the memory estimates are looking at, it really requires a statistical model, understanding chance behavior of turning over cards in this type of game, and realizing how many steps back did you have to go to correctly remember. How long would your memory have to stay in place to correctly predict where to turn the correct card. So just instead of, in this case, you reduce the complexity of the data from the probability curve that the memory is still in place by characterizing it with just 2 parameters of a Weibull function, which is a standard way to analyze survival of memory, or survival statistics in general. People's death, a factory widget, how long is it going to work? When will it break? So the examples you've seen, just to review, are activity monitoring in the home, cognitive monitoring, motor speed, getting it from a wide variety. We also have motor estimates from mouse movements. There's a lot of free data out there. But if you're going to store it all, it's the big data issues loom large, and how to combine these in an intelligent way. Sleep, depression. We have some people working on affect on the phone, linguistic analysis, medication management, context-aware reminding, socialization, and we also have physical exercise data. Now that's data intensive as well. Our new project on physical exercise uses the Kinect camera, so we're having video analysis. It's represented instead of raw video. We have this Kinect skeleton representation that we're then comparing to what's seen from the physical therapist doing the same exercises in order to give automated feedback to the person. But that kind of data, we're having lots of trouble figuring out how to store it well, how to compress it, how to make intelligent flexibility measures from what you see in the skeleton representation. Can you just extract the essence of what you're seeing instead of carrying the whole video to the server? So there's the issue of collecting all this big data from the home, and I've just given you examples that I had handy. There's other, you can look at social media, people's networks of friends, GPS on your mobile phone as you go out and about, how many miles are you covering, how far away from home do you get? Good indicator of socialization. So many opportunities. I've just given you the ones that I personally have access to, some nice visualizations, and giving you examples of things that are so cheap and ubiquitous and really an untapped resource for clinical use. But the real trick is to close the loop with an intervention based on this, and it's one of the reasons for collecting this kind of data. And so what what we've been working on with Health Coaching Project, and that I'd like to also just acknowledge that we have a collaboration with Finland and two visitors here. We have Jani Veno and Jose Perez Macias visiting from the Tampere University of Technology, and we'll be working on coaching similar to the platform that we are using here. But the important issue for health coaching is that you can't have, we can no longer have a separate system for diabetes, another one for weight management, another one, you know, if we're going to start working on sleep, are we going to have another computer system that doesn't connect to the electronic health record or is integrated into a person's approach in their personal health record? So we need modular approaches that are tailored to individuals. And what we've seen is that to accomplish this, you really have to have sophisticated user models, and medical informatics approaches have been really important in moving into this area in order to generate automatic messages that a coach can use to handle a scalable approach to delivering these types of home interventions. This is just a quick description of the process and the information that we use and how we use the data that's streaming in from the home to update a dynamic user model and tailor action plans as well as messages to help with just-in-time encouragement and feedback. So the thing I want to emphasize here is that there's going to be a coach interface, participant interface, and more recently, Steve Williamson has been working on a needs assessment for a family interface. He's hoping to deliver it by mobile phone and has been doing some background work in understanding family needs or informal caregiver needs for being in the loop in a productive way, a meaningful member of the care team. So and one of the big issues of big data that I should mention is the alerting. How do you involve the correct person at what point in time? The World Health Organization just recently commissioned a report on task shifting. The main issue here, when you get a lot of engineers working on a system like this, they typically want to show the doctor all the data. And it would overwhelm someone. Even if you're only looking at blood glucose levels for a diabetes patient, no doctor wants to see the whole thing. Those measurements are made for just-in-time care in the home, in this case for the patient themselves or for the informal family member that's helping. Now, even nurse care managers don't want to see absolutely everything and can't get an alert without just tuning off. And when you have big data, say you're doing fall detection and you're constantly looking at the accelerometer and every little signal that's happening, say you're correct for 1,000 events, but you make one mistake per day. Well, are you going to call the ambulance once a day? Typically, one false positive per day is way too much, even though it's been an algorithm that's been looking at 1,000 different events throughout the day. The notion of over-alerting has killed the business plan of many companies that have attempted to go into this area. Usability becomes a big, big issue, and defining how to have a spectrum of alerts is one approach we've tried to take, and one good reason for involving informal family caregivers or friends, a network, social network, in low-cost, early being the front line out there. So the other thing is that these kinds of systems need to run for the long term. Many research projects go a couple of weeks, you test it and you're done. But as we know, health behavior change for chronic conditions or lifestyle conditions are a lifetime. We need to develop interventions that are fun, meaningful, have variety, they're tailored, they feel like they're helping, and make use of lower cost local personnel that really understand the notion of task shifting. We find that physicians, nurses, typical clinicians have not necessarily been trained in motivational interviewing, health behavior change techniques, whereas personal coaches get that training completely, but need standard protocols and need an understanding, or the algorithms need to know when to alert to a higher level. So a lot of this effort in big data is about alerting and task shifting. And family members and informal caregivers can be part of that task shifting. So we've seen these modules. I'm just going to quickly, as a reminder, just show what we're currently doing is either presenting YouTube videos and monitoring activity from motion sensors, but we also have the Interactive Connect for physical exercise. Sleep modules, we have relaxation YouTube videos, music therapy, sleep hygiene recommendations, and based on sleep assessments that move them into either anxiety therapy or time of day, like do your physical exercise earlier in the day, or the napping. You've seen the socialization. Participants receive a weekly message, a featured news story to keep it fresh, and they have a tailored action plan. The coach sees a different type of interface. But now to step back and think, given these kinds of examples and what else you know about data that's being monitored in the home, is that the connection with clinical outcomes and diagnosis for some of these cheap, ubiquitous data types has been so unexplored. Whoever sees the data first is going to likely to make a big discovery, especially in the area of sleep and depression and motor speed. This type of data is just really critical for personalizing interpretation of clinical events, because you need to look at within subject trends and not compare people to a population. And variability in itself is an important indicator and a feature that you cannot get when you only take a measurement in a clinician's office. So the implications now are that in order to handle this and understand what behaviors are normal for an individual requires a lot of new modeling techniques and data models to infer patient state. We need to be sure we understand how to model context and not try to average it out. We need sophisticated user models in order to tailor the interventions. And one thing we haven't talked about yet are, once you're in the realm of behaviors, privacy and security loom large. With genetic data, of course, the security and privacy there are big issues, because that completely defines many of the disease risks they have. But here, we're talking about sleep behaviors, what they're doing throughout the day. Who do they want to share the data with? It's not absolute privacy and security, but a definition of an individual's preference for how they share the data. They may want to share data with a particular family member and not others. They need to share the data with the coach. But what data gets brought up to the physician? And the other issue, of course, for big data is how do you summarize it and for whom? The physician should see one type of report, a nurse should see another, a nurse care manager should see another, a coach another, family member another. And these types of, that's one reason Steve was doing qualitative early needs assessment before even starting to build the family interface in a mobile device, because we need to understand not only what data, but what quantization and what format works best for them and what timing. So this means there's many challenges here. The data is frequent but noisy and context dependent when you deal with behaviors. We need to understand the noise associated with a particular sensor, how to integrate data from a variety of sensors. when you're doing data fusion, you might have, in one context, one particular variable would be a good, reliable indicator while another would not. So this means we need to be able to characterize in our data types the source of the data, how it was sampled. We just heard from, visiting with some of the Orcatech members about, well, what metadata do you need for each sensor. You even need to know about the battery. Many of the clocks start slowing down. A lot of things that we don't anticipate, that we've come up with like 25 different characterizations for each sensor, and it's just not well defined how to best represent the quality of the data. And that's not been a problem for anybody else working with a very specific, like web clicks or genetic data. This new type of behavioral data is bringing out many, many new issues that have to be addressed. We need to understand how it's sampled. Do you do even sampling or do intelligent sparse sampling during important times? And I already mentioned the problem with alert fatigue and how dangerous it can be if you don't treat that as an important priority. Now, this isn't necessarily a readable slide. I just want to point you to the Gartner report on the hype cycle for big data that came out in July of last year. They go along from the technology trigger, the peak of inflated expectations, the trough of disillusionment, to the slope of enlightenment and the plateau of productivity. Where behavior data sits on this, we don't know, but clearly there's a lot of hype, and everybody wants to be talking about big data, and I'm quite embarrassed to be part of that. But I do want to make sure that behavioral data is at least considered on par with the rest of the data types that are being considered by NIH. Now, just as winding up, I wanted to give you a couple of new approaches that have been out there for data visualization. Deb Roy gave a TED talk last year where he monitored his son usage of the word water, where did it occur in the house, and in what context, and has video of everything. Now that's big data, but that's just one little boy in one family. How does that extrapolate? But here's the type of plot he used, so that the peaks reflect lots of water over the year, the word being said, and the rest shows a little bit of the context, something like the typical word plots that you see. That's a diagram of their apartment. Now, DARPA's working on topological analysis of big data sets, where you take a highly multidimensional space and try to figure out, well, what are the connections where you can use parameters to summarize and then plot those, and what relationship do they have? And I can't really explain this approach or this particular application, but what I do want to hold on to is that this is a technique that might be useful as we're exploring huge multidimensional data sets. So in the training that we're trying to propose, what are the techniques that are required? What should people know at least a little bit about so they know they can use the appropriate tool for the problem? There's standard statistical modeling that we're all taught in DMICE, and you consider that to be a black box, and that's the typical regression, and you look at associations. Unsupervised learning and clustering is also kind of black box statistical approach, even though it's starting to look towards machine learning. Then if you add in functional equations and invariants and add in constraints that you know about the system, you can get stronger relationships. Then there's process models that we need to consider. Decision models, time series, graph models, simulation. But all the while, typically people are taught and develop an expertise in one or two of these. And then they go around looking for appropriate problems. So it's the hammer looking for the nail. What we're trying to do in the big data training is give not only the behavioral researchers but also the modelers, the engineers, computer scientists, more of an idea of what tools are available, especially with data visualization, making sure they understand the data. This is really key with behavioral data. You need to understand what's noise. Did your data come in correctly? What are the potential biases? How do you correct for it? And this is one of my favorite quotes from John Tukey, that an approximate answer to the right problem is worth a lot more than an exact answer to an approximate problem. This is we're all at risk in academia for drifting towards problems that are easily measurable and easily publishable, as opposed to stepping back and figuring out what's the real crux of the problem here. One good example is patient utilities in doing a decision analysis. We spend a lot of money on clinical trials to get the probabilities just right down to a really well understood prognosis, and then have no information on how to use patient preferences on the other part of developing expected utility for making a high-quality individual decision for a particular patient. And I want to make sure in the training, as we try to help people look at their data sets, make sure they're asking important questions and not just doing random machine learning to see what associations pop up. Using structural equation modeling to figure out when you do have constraints that you know, how can you best represent them? In the way that we did with some of the computer games, and separating out, we know there's a search phase, a recall phase, and a cognitive phase, or at least we're going to try to model it that way and extract stronger relationships. So the real questions that people that are starting to move into a new field like this are what variables are you going to include? And what models should I use? What features are going to be important? How do I even get started in defining some features and picking them? Anyway, I would love to have a discussion afterwards if anybody's interested in helping us define what the big data skill sets are in training, how to do intelligent data sampling, data visualization, the things that we've mentioned here. If you can be thinking about what tools would you want to see if you were working in this new area, what you would need training in the clinical domain, and the clinicians would need training at least to communicate with the modelers. Really important to have clinicians involved. And additionally, we see that in many institutions, people don't have technical people on staff to help with the data security and how to represent the data, how to de-identify it appropriately. And we're hoping to have an infrastructure or a facility that will help IRBs in analyzing their projects as they go through, because usually they can't really make a recommendation or even approve something intelligently that comes through with the new mobile devices, for example. Do they know that the data is not hackable, or that how easy it is to lose the security of data in some of these cases? So we need standard guidelines to help people. So this is my last slide in take-home messages. We know we're shifting to out-of-hospital care. It's important to get to the home, and there's certainly a need for these behavioral metrics. And they can be low-cost and scalable, but do require incredible intelligent algorithms to make those reasonable inferences. And it just really hasn't been explored enough. And by moving into this area and getting down and dirty with it, I'm sure you'll be on the forefront of some important discoveries. So many challenges, but I'd like to get everyone's help here. If you have suggestions and want to participate, I'm happy to take your suggestions and questions at this point. Thanks. there's got to be a suggestion. Yeah, Michael.
This is more of a question than a suggestion, but so you know my interest in this area.
Yes, I do.
From the past, but I'd worked on a project at my current place of employment for the ONC, and we were talking about, they were interested in patient-generated health data. And I think it was Charlie Safran made some comment when we interviewed him, which said there's a difference between sensing the data and making sense of the data. And in the course of your talk, showed the behavioral data that you would obviously use to try to change health behaviors with health coaching. But in between, there were signs of places where there were warning signals, like the downward trend of the walking speed that the provider for that patient would want to know about. So I'm just trying to think about how do you grab those very important pieces of data and get them over to the doctor or into the medical record?
The first step is that we need to do research to really see what trends are significant. Like we could see the slope of that individual, and we've looked at the slope of populations of people that have mild cognitive impairment and populations that are cognitively intact, but those cognitively intact usually have a mix of abnormals that will be diagnosed 2 years later. Now, the research first needs to go into to understand what's the clinical protocol, what's a doctor going to do with it. The stage we're in right now is that we've made all these measurements and we've shown some alarming associations. Like, for example, it looked like somebody has stroke. But if you see a sudden downward movement in the walking speed, what kind of alert are you going to send and what are you going to tell the doctor? We don't know at this time. We're just, we have enough data to say, wow, this looks important. This looks more diagnostic than a blood test at this point in time, or asking somebody on the phone, how you doing? We know there's information there, but the next step is to define some clinical trials to associate behavioral data with clinical outcomes and prove that we have an early diagnostic measure. Now, one of our approaches now is to try to, if it's a cognitive indicator, to start looking at hepatitis C patients going on interferon, which changes their cognitive performance, or breast cancer chemo brain, where there's cognitive problems while they're on chemo and takes a while to recover. And do they ever recover? Nobody's, these once-a-year tests are not really going to be as helpful but we've first gone in baby steps, proved there's a correspondence with the standard tests, and we think we can do a lot better than the standard tests, not only because we're getting continuous measures, but we think we're extracting even better measures of performance than somebody sitting in once a year in an unfamiliar place, taking a test that they might not understand, might have English as a second language, and a variety of other complicating factors. So that's the first step, and then to prove the correspondence with clinical outcomes. We're not ready to tell physicians what to do with the data yet. Not this data, anyway. We certainly know what to do with blood glucose and heart failure data, but most of what they're measuring for heart failure, even weight, the symptoms, shortness of breath, tiredness, fatigue, that's not useful to the doctor. It's for immediate management, and a nurse care manager can intervene. If there's fluid overload, change the diuretic. But the task shifting is a real important message here. The right person should be getting the data at the right frequency, but not to overload physicians with volumes of data that they can't act upon. That's a big message.
So I'll let people
mill around and give me suggestions, please.
Yeah. So thank you, everyone.
Thanks.